versus a 3-wall dehiscence. So that fourth wall is usually always the buccal bone. Okay, that buccal bone, as you'll see here, you always want to make sure that this bone is no more than 1/3, lower than 1/3 of the height of the implant. So if this way, this is the halfway mark, you don't want this to be lower than 1/3 from the top. You can still be able to graft this bone as long as you have the palatal bone, you have bone on this wall, bone on this wall, and bone from the palate that's going to lead to bone fill. Then you can pack the bone graft, put your membrane, make sure the implant is placed a little bit deeper, a little bit more palatal, hiding it away from the, outer world. Basically, that's one way to categorize it, the 1/3 mark. Also, a number. You don't want that dehiscence to be greater than 5 millimeters. So if you see many threads, you want to stay away from it. I like to keep it at like 2 or 3 millimeters, just to make sure that there's no issues. When in doubt, deeper is better. But really, where's ideal? You want to be 3 millimeters apical to your adjacent soft tissue. Okay? So let's see if we have a... So if your tissue is over here, we're at the CEJ, you want this implant to be 3 millimeters apical. Key. Always remember that. 3 millimeters at least. At least. So 4 would even be better. Apical to the adjacent soft tissue. Usually, where's that soft tissue? Usually it's at the CEJ. But what if you have recession on that tooth? If you have recession, so if our tissue is here, and we have about 2 millimeters of recession, we have to still go at least 3 millimeters apical to that tissue. Now, if you're placing a number 7, are we looking at your adjacent tissue being number 8 or number 6? If you're aiming something, always be closer to the midline, because that's our reference. People always look at you at the midline. The more discrepancies that are going on in the distal portion is not as seen as much. So when in doubt, if you have a lot of recession on your number 6, but number 8 is okay, you want to place it a little bit more closer to the number 8. Buccolingually, where do we want to place our implant? We always want to draw a line, and I would say this is not the line to look at. The line to look at is where the most outer portion of this tooth and the most outer portion of this tooth meet. Right at that line, you never want the implant to be touching that line. Always want it to be more palatal than that line. If it comes a little bit close to that line, that's where you might have some issues. And that's when you see the grayness. As a result, what do we have to do? We can't place 6 millimeter implants in this area. We can't, maybe we might not even be able to place 5 millimeter implant. Okay? I remember trying to place a 4.5 millimeter implant or 4, and I didn't get stability. I went wider, and I was very close to that line. And I remember on the final result, I noticed, I said, when the patient came back, that it would have been better if it was a little bit thinner. So it does really make a difference. If you do go with a wider implant, though, you have to place it deeper. This is for a single missing tooth. If you have another tooth that's missing, you can draw a line going to the next tooth over, and kind of, at that time it may not be a line, it may be a little curve, but you can kind of visualize. Whenever I place an implant, I always visualize how the crown looks in my head. Always, always, always. You have to. You have to do that wax up, diagnostic wax up in your head, so that you know exactly where to place the implant. Okay? And one of the key things is coming out of the cingulum, which we'll talk about. So even having a cushion of 2 millimeters to this line, this is the line I was talking to you about, is key. Now, this is a really important picture too, because it shows that we need at least 1.5 millimeters or 2 millimeters between an implant and a tooth. Between implants, we like to have at least 3 millimeters. In the number 8, number 9 area, we rather have like 4, okay, because that papilla is very hard to keep. And again, 1.5 to 2 millimeters here, okay? So if you, and we're gonna show you a case, you can measure this distance that you have and then figure out what size implants you're gonna use, how much space is between them. You can map it out on an X-ray or a CT scan so you can see, sometimes you may not have room for this implant, or you may not have room for this implant. That's when you do implant and do a bridge. If you ever want to make a case more aesthetic, and you might have to, comment on this. They sometimes say even if you want bridging in this area, in the front area, is a little bit, with implants, is more aesthetic than having more implants in a row. Okay? So just because they're missing 4 teeth doesn't mean they need 4 implants. If they have a high smile line, you're almost better off doing 2 implants, because then you can mold the tissue, and it'll make ovate pontics on number 8 and number 9, and it's going to look more natural. Now, also you got to keep in mind your adjacent root angulation. So if this root is angled in this direction, then it may not be possible to place this implant. Okay? At that point, like I was saying before, you may need to do a distal cantilever from this tooth over here. So in general, if we want to do a cantilever, it's better to cantilever mesially, if possible. But in the front, the forces that we place on the front are about 4 times less than the forces that we put on the back. So cantilevering in the front is a little bit more okay. And if we're going to cantilever in the front because of a bone defect or root angulation, that's just something to keep in mind. It may be okay. All right. Again, this is about 3.6 millimeters apart. That's perfect. This is showing where the distance between the CEJ and the existing bone. Now, when you're doing an immediate implant, okay, and you have periodontal disease, so there is a lot of bone loss. So let's say this bone all of a sudden is over here, but the tissue is here. When you take out that tooth, that tissue is going to collapse. So you have to let the patient know that when I take out these teeth, your teeth are going to be longer at the end. Are you okay with that? This is how it's going to look. Maybe you can show them on a wax up or on their mouth. Show them on their gum line. Your teeth are going to be this long. Yeah, maybe I can trim a little way from the incisal edge, but you're going to have longer teeth. You can sometimes, instead of having all white, you could have pink porcelain for that area as well. But if they have a high smile line, they may not like pink porcelain either. Okay? These are all discussions we need to have. Managing and talking and communicating with your patient is key.